Hi everyone, good evening. Thank you for joining us for the Promoting Mobility and Preventing Falls in the Older Population with the University of Sydney. My name is Lauren Thomas and I am the CPD Program Officer with Central and Eastern Sydney PHN. Also with us tonight is Jason Phillips, Aged Care and Strategic Projects Manager. I would firstly like to start by acknowledging the traditional custodians and sovereign people across the land on which we work. I recognise their continuing connection to land, water and community and pay respects to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues joining us today. At the end of the webinar, we have an evaluation survey, so we'd really appreciate your feedback. That will be sent out in an email as well after the event and in the chat box. And that will also allow us to do your certificates of attendance. For GPs joining us this evening, this activity is a self-report activity, so you'll need to upload the hours to your RSCGP dashboard. We also have opportunity for questions, so they will go through the Q&A box just below in your menu. We also have some upcoming events that I'd like to draw your attention to. Next Tuesday, we have our secure messaging and HealthLink smart forms for allied health. That will be a lunch and learn webinar. And we also have on the Tuesday, 19th of September, a comprehensive geriatric assessment webinar. And just some CPR courses if anyone is interested. Registrations are available on our website. We also have another CPD program survey. If you wish to complete, that will be open until Friday the 18th of August, and you can just use the QR code. We also have, there's also emotional wellbeing for older persons program, which provides psychological and psychosocial services for older people residing in RSEFs in both the Sydney and South East Sydney local health districts. And lastly, if you'd like to check the CESPN website for more information on the Healthy Aging Hub and Care Finders. I would now like to introduce Dr. Martina Gleeson, who will be, who's a practicing GP, who will be providing a health pathways demonstration. Thanks, Martina.
You're welcome, Lauren, and thank you everybody for joining tonight. Just checking, Lauren, you can see those slides now?
Yes, I can. Thank you.
Excellent. Thank you. So it's my lovely duty to be able to let you know which health pathways on both of our health pathways sites will support you when you go back to your rooms, having been inspired by tonight's talk, and then want to find some resources to help you through the day with your patients. Most of you would be aware that CESFN has two health pathways teams, the Sydney Health Pathways team and the Southeastern Sydney Health Pathways team. And it would be good if I could get this to advance. Okay, so if you have never had a login to Health Pathways before, here are the QR codes that can take you to either of the sites. If you've already got a username and password, you can use the same username and password for both sites. So if you can't find what you're looking for on one of the sites, you can check with the other one. But we usually advise that people use the region that their patient will be seeking services in. So if you live across the border of one, but you're referring the patient across into the other service, use the health pathways that suits for that region that you're sending the patient into. If you don't have a login, just there's a request for registration on the homepage of both sites, and the teams are very responsive and they'll give you a login straight away. We don't publish them anymore because these are recorded, and the logins are mostly for health practitioners. Just a few little tips on using health pathways. If you're looking for something and you're not quite sure where to find it, up in the top search bar you can type in your search content. So for example, if you're looking for something on denosumab, if you type it up the top, you'll be given an option for a web page where you're likely to find it. And then when you get to the page, if you click on that expand or the button that's over on the right, and then use your word prompt, so Control F for control find, and then type in the word you're looking for, and those words will be highlighted in the pathway to help you find them. As I said, use the pathway that your patient will be accessing services from. Just to give you an idea of the kinds of pathways that we have that support tonight's talk, Southeastern Sydney Pathways have falls prevention programs and balance and strength tests. They've got a pathway on older adults health assessment and medication management and polypharmacy in older people and osteoporosis. And we also have exercise physiology and physiotherapy assessment for adults to help you find services in your region that will serve your patients with these. South Sydney has a few more. They've got quite a extensive falls suite of pathways, and they also have the physical activity pathways for helping you access services and how to do risk and wellbeing assessments using the fracture risk assessment, the older person's adult health assessment, and medication management, and a pathway on frail but stable older adults. Just a little bit of a plug. If there is a pathway that you're looking for and you can't find it in the Southeastern Sydney site, please write to us. That email address is there, and nominate a pathway, because we're planning our program of work for next year, and we really, really value the feedback from GPs on what they're finding they would like help with. We actually weight that kind of feedback very highly. And then we also have a pathway called GP to GP colleague. And so if you provide special services and you're happy to work as a consultant for other GPs in your area of special interest, please let us know, and we'll list you on that pathway to help other GPs find you if you provide a specialised service. And just final one, we're currently reviewing these listed pathways. And so if you've used them and you think that there's room for improvement, or you're aware of things that you've looked for and haven't found, please hit that send feedback button, and you'll get through to the team, and we will incorporate your feedback into what we're doing at the moment. Here's our contact details. Thanks very much, Lauren.
Thank you, Martina. Thanks for that. Also, a copy of the slides that Martina's just shown will be sent in the post-event email. Now we can get started. So I'd like to introduce our speaker for tonight, Professor Cathie Sherrington from the School of Public Health at University of Sydney. Professor Sherrington leads the 30-person physical activity, ageing and disability research stream at the Sydney Local Health District-based Institute for Musculoskeletal Health. She also has 10 years clinical physiotherapy experience in aged care and rehabilitation settings, and was one of the founders of the Physiotherapy Evidence Database. Pedro, welcome, Dr. Sherrington.
Thank you very much. And yeah, thanks very much for the opportunity to talk to you. And thanks very much, everyone, for coming along. So yeah, I'm going to really talk about promoting mobility and preventing falls in older people. A little bit of kind of the theoretical aspects from my perspective, and then some of the evidence. A bit also of an update of the a draft update of the Australian Falls Prevention Guidelines that are going to be open for consultation soon. As Lauren said, I have a background as a physio, but then I've done a Masters of Public Health and PhD because I really feel like mobility, falls and physical activity really are the kind of intersection between physiotherapy and clinical practice, but then also public health initiatives. I'm also a fellow of the Australian College of Physiotherapists and also the Australian Academy of Health and Medical Sciences. So yeah, basically what I'm going to argue is that falls, poor mobility and physical inactivity are major population health challenges that are connected, complex and neglected, and are obviously going to increase with our ageing population. and that we really need implementation and scale up of evidence-based solutions. And we really need to work together and to have a lot of strategies to actually achieve this. And it's fantastic to see the health pathways, which is obviously an important piece of the puzzle. And as GPs or allied health practitioners in the community or nurses, you can obviously have a really crucial role in this area. And so, as Lauren said, I'm from the Institute for Musculoskeletal Health, and so we're a partnership between the University of Sydney and the Sydney Local Health District. We also are part of a university flagship centre on musculoskeletal health. And so my colleagues focus on back pain and musculoskeletal conditions, and my team focuses on physical activity, ageing and disability. So we're about kind of the health of the musculoskeletal system rather than musculoskeletal conditions in our group. I work with Professor Anne Tiedemann and Associate Professor Leanne Hassett. Our team also hosts PEDRO, which is the physiotherapy evidence database, which indexes sort of summaries of evidence to guide physiotherapy practice, and that's freely available on the internet. And this is the people from our team focusing on physical activity, ageing and disability. So the top line's our postdoctoral fellows, the next line's our PhD students, and many of whom are experienced health professionals themselves. We got physios, also exercise physiologists. And then the bottom line is our kind of research team who really help implement the studies that we undertake. And so, as we know, population ageing is a huge issue. And so the UN have declared this decade of healthy ageing, and particularly because people age 60 plus now outnumber children younger than 5. And up until between basically now and 2050, or between 2015 and 2050, the world population of older adults will double to being 22%. And I'm sure you're seeing the impact of this firsthand in your daily work. But basically, that's just going to keep increasing. And so, really, we probably need to work out how to do things differently in health, and probably have a greater focus on prevention as well. So I really like this model from the WHO, from their report on ageing and health. And so I guess this really brings together the concept of intrinsic capacity and also functional ability. And so rather than focusing on particular conditions, really focusing on kind of physical and also mental function. And so they talk about intrinsic capacity as being then made up of a number of other characteristics, so genetic inheritance, health characteristics, and so this is where illness, but also behaviour comes in, and then personal characteristics around the side. So that's probably issues like socioeconomic status, cultural background, etc. And so they also talk about these components being part of intrinsic capacity, but then functional ability being a broader concept, which is about how we function in society. And so that's where things like walking aids, other devices, any sort of assistive technology, as well as environmental modifications are important because that's really kind of what enables people with impairments in intrinsic capacity to still have independence and participate fully in the community. And so, probably our society has some limitations there, probably a lot of room for improvement. And so within that WHO report, they also talk about different trajectories. And so trajectory A is so really the interaction between physical capacity and age, or the relationship between those. And that's really the ideal trajectory, where people are maintaining high intrinsic capacity until the end of life and then dropping off more quickly. Trajectory B is people going along well initially, but then having some type of interruption. So whether that's a major illness or an injury, or something that really interferes with that physical capacity. And then ideally people would then recover. And with sort of optimal rehabilitation, people might be able to get back onto that trajectory A. Some people, if the issues are not well treated, then may have a greater decline at that time. And then trajectory C, which is unfortunately also quite common, is basically a gradual deterioration in physical capacity throughout life. And so that's a kind of theoretical model, but the key question is, I guess, what can we actually do about these things? And so it's important to understand, I guess, different contributors to different concepts that contribute to that. And so an important aspect is really mobility, which in the WHO ICF, so the International Classification of Functioning, they talk about mobility as being made up of tasks, so rolling over, sitting, standing and walking. And then, as I'm sure you're also well aware, many Australians actually report difficulties with mobility. And so national surveys have actually found that 1.2 million Australians report a difficulty or an inability to walk. Obviously, some of those people will be maintaining independence in other ways, so through wheelchairs particularly, or other devices. But I think there's probably also a lot of people who are not fully using those and don't have access to those. So that's why mobility really ties in really strongly with care needs. But so it's the key point really there is that it's actually more about function than age. This is a friend of mine who I run regularly with, who's actually in her 70s. And so she's obviously functioning much better than many 70-year-olds. And so it's not really about age, it's actually about physical function. And so we've known for a long time that physical activity ties in with physical function. And so I really like this quote from Plato, which talks about the lack of activity destroying the good condition of every human being, while movement and methodical physical exercise save it and preserve it. And so WHO defines physical activity as being any bodily movement produced by skeletal muscles that requires energy expenditure. And so physical activity covers movement undertaken during leisure, also for transport or as part of work. And so exercise is a sort of subset of physical activity. And so physical activity has many benefits, as you're very well aware. And so I like this summary from the UK Chief Medical Officer's report on physical activity. I think it's a really nice infographic which really talks about all the different benefits of physical activity in terms of quality of life, health, disease prevention, and also management. I also really like the message from there, which is really strongly based on the evidence that some activity is good, but more is better. But it's never too late to start. So there's also strong evidence that we can improve things in older age. And so make a start today. And every minute counts as another kind of slogan that they've used, which is the idea that it's actually better that people do something rather than nothing. And so then more recently, the World Health Organization released their updated physical activity guidelines, which is in this paper in the British Journal of Sports Medicine, and also in the full booklet on the World Health Organization website. And so it talks about doing 150 to 300 minutes of moderate intensity aerobic physical activity for health benefits. you might realise that that's actually increased that upper amount, which is difficult in terms of encouraging people to do it, but really is based on the evidence. And so if people are doing more vigorous activity, though, they can do less aerobic activity, so 75 to 150 minutes. And then there's additional guidelines about doing muscle strengthening activities, and for older adults, undertaking multi-component activities that focuses on functional balance and strength. So 3 days a week, which can be as part of the overall physical activity. And so a lot of that is based on both observational studies and trials. We do hear a bit about sedentary behaviour these days, and I really like this analysis by some people. I've actually forgotten which one, but I think Norway, certainly a Scandinavian country. And so they've actually done a massive meta-analysis of data from 850,000 people, and they've looked at the interaction between sedentary behaviour and more vigorous physical activity. And so they've basically found that in the people who don't do so much physical activity or exercise, really. So this is in minutes, which is a way of measuring the dose and intensity of exercise. And so they find this very strong relationship. And this is cardiovascular and cancer mortality shown here. And so, really very strong relationship with more sitting being associated with worse health outcomes and greater mortality. But then in these people here who are more active and really are meeting those guidelines for moderate and vigorous physical activity, that relationship with sedentary behaviour actually disappears. And so that's very reassuring for those of us who unfortunately need to spend quite a bit of time sitting in our jobs, but it looks like we can actually decrease the health risks of that by fitting in that amount of physical activity or moderate to vigorous physical activity as recommended by the guidelines. And so colleagues in the School of Public Health have also looked, modelled the cost of physical inactivity worldwide, and have basically found that there's up to $54 billion worldwide of healthcare costs, which could actually be avoided if we were able to support people to be more active. So it's obviously really a massive public health issue. So where do falls fit in? And so falls are basically unintentionally landing on the ground, floor, or other lower surface due to a loss of balance. And at least 1 in 3 people aged 65 actually fall each year, which is 1.4 million Australians. So I really think this is a large but neglected public health issue. And with a smaller proportion of those people, but still a really important number, will actually end up in hospital. And so there's 233,000 people hospitalised for falls each year in Australia. And some of those people are people being admitted more than once. And sadly, more than 5,000 people actually die from a fall each year in Australia. And that's where I really think this is a neglected public health problem. That's quite a bit more than deaths from other things that we actually hear a lot more about. And so so as I'll talk about a little bit later on, we have an NHMRC funded Centre of Research Excellence in the prevention of falls injuries. And through that, we worked also with people from the Australia and New Zealand Falls Prevention Society and Neuroscience Research Australia. And so we tried to try and summarize the information and better communicate it to be able to better get the message out. And so we used this data from the Australian Institute of Health and Welfare, which talks about reasons for injury hospitalisation. And you can see falls is by far the most common reason. And that in just older adults actually costs our health system $2.3 billion a year. And to better communicate the commonness of these problems, we calculated that every day there's 364 Australians aged 65 plus having a fall that puts them in hospital, and that these numbers are just going to increase with our increasing population of older adults. So there really is quite an urgent need to do things differently. And so each fall, as I'm sure you're also aware, is quite complex and is really the interaction between the person's physiology, their behaviour and an environmental hazard. So usually the environmental hazard will actually trigger either a trip or slip. So, such as something spilt like in this picture, but it doesn't necessarily mean the environmental hazard is the only problem. So with with some hazards, a person with a better physical function would actually be able to recover from such a hazard. Some hazards would obviously not be the case, like anyone would fall in some situations, but in some situations, people with better physical function would actually be able to recover. And so that's where behaviour is also actually important. And the way I think about that is actually from a talk that I gave for retired physios. And there was a retired physio who clearly had something neurological going on. She was walking with a stick. We were in the centre of the city. She'd managed to catch a bus there by herself. But she said she'd actually never had a fall. And that really was because of her awareness of her physical function and her limitations and the care with which she was interacting with the environment. But not everyone is as able to do that. And so factors that have been found to kind of influence behaviour and influence the way that people interact with the environment are basically cognitive impairment, people's level of insight into their physical functioning, people's attitudes. Some people are more risk takers than others, and also distraction. So people do fall while like rushing to answer the phone or, while distracted by something else. People often seem to fall on a day of a big event where they're distracted. And then if we think about the physical function, the way I like to think about it is that the risk factors for falls are things, impairments of things that normally enable us to recover from an environmental trigger. And so if we're walking along the street, there's something uneven, tree root or an uneven bit of a footpath. If we're paying attention and if we've got good vision, then we can see that coming. Even if we don't have good vision, we might be using a stick or something like that to compensate for that. If we haven't seen it in time and if we're starting to fall or we can feel the hazard, then it's sensation that helps us detect that. And then we need good reaction time to be able to respond to that. We need good muscle strength to be able to generate enough force to hold ourselves upright to prevent a fall or to take an alternative step. And that's probably muscle power that's important as well there. So the ability to generate force quickly. And then we need good balance. And so balance has been found to explain around 20% of around 50%, half of the variability in the risk of falling. And so balance is really the ability to coordinate and integrate the other functions, both in terms of the inputs and also the outputs. And so balance really is the control of one's body in space. And obviously we need good cardiovascular function to avoid falling as well. And so, for a small subgroup of people, it will be cardiovascular reasons that they fall. But when we ask people why they've fallen, a loss of balance or a legs giving way is by far and above the most common reason that people report. And then these physical factors themselves are influenced by different diseases, medications, aging itself. So there obviously is such a thing as physiological aging. But inactivity obviously plays a massive role in that as well. And how I like to conceptualize that is by thinking about masters athletes. And so we know a masters athlete is going to be functioning a lot better than an average person or an inactive person. And so there really does seem to be a role of physical activity in maintaining physical function. But still, those masters athletes, their world records are slower than the younger athletes. And so, there is also such a thing as physiological aging. We can't prevent it all with exercise. So in summary then, basically a fall happens when an individual's physiology can't cope with the task that they're trying to undertake and the environment in which the task is being undertaken. And so people who have better physical function will actually still fall, but they'll fall in more challenging environments and doing more challenging activities. And that's where fall really is on a continuum. And so that's even like sporting injuries or, falls while bushwalking or while walking on ice are really the same type of thing, but that's a person with a better physical function being in a challenging environment where their function isn't good enough to cope with those environmental challenges. But a person with more impaired physical function can fall in less challenging environments, so doing less challenging activities. So obviously such as sitting down or walking across the room. And exercise has a potential to impact on many of these falls risk factors. And so that model from WHO I presented is kind of theoretical. So I think it's helpful to look where the data actually, whether data supports that. So both in terms of long-term observations and in terms of being able to intervene to change these trajectories. And so we've done some work with the Australian Longitudinal Study on Women's Health. And we basically found really strong confirmation of those relationships. And so this is physical function by levels of physical activity. And the people with the lowest level of physical activity, so who over a kind of 20-year period, who were consistently had consistently low levels of physical activity, did actually start with more impaired physical function and then deteriorated at a greater rate with increased age. Whereas these people up here, they still did have some deterioration with increased age. So these are the consistently highly active people, but the deterioration was at a slower rate. So again, that's observational data. This did use kind of modelling and epidemiological techniques to try and address for confounders, but it is still observational, but it does really show those relationships. But then physical activity behaviour is also different by level of physical function. So it might work the other way around. And this is work that Leanne from our group did with the OSPLAY data, which is a large representative data set looking at physical activity and sport in Australians. And in the physical activity area, we often say that activity decreases with increased age, but we actually found in this study that that was only the case for people with some type of disability. So the people with good physical function actually maintained a similar level of physical activity throughout life, and even perhaps did a little bit more on as they got closer to retirement or after retirement. And that makes sense in terms of the people that we see around the active retirees. And so it also, to me, points to the need to both target and also provide opportunities for those people who do have impaired physical function. And we found something similar also in the longitudinal study of women's health. So again, those people with physical function limitation were actually less active and kept being less active throughout the 24 years of follow-up. So the key point there, I think that basically falls, physical activity and poor mobility are all interrelated, and we need to urgently work out how to actually address this. And so we did some work for WHO where we actually did a review of programs and services that provided physical activity for older adults. There was actually a massive amount of evidence, and so we ended up pulling out, there were the 100 trials that were larger and of better quality. And we basically found strong impacts across a whole lot of different outcomes of physical activity delivered in different ways. And so this is a way just sort of graphically of showing the studies where there was between group differences, where more than half the between group differences were in the positive direction. And anything that's blue, more than half of the differences were in the positive direction. And so you can see that basically for all the different types of activity, actually, if you considered all outcomes together, they all had impacts. And we were then able to explore it more in more detail, looking then at different outcomes and different types of activity. And again, a lot of effects are really quite positive across a range of outcomes, and you can get effects from different types of activity as well. Probably the stronger effects are in where there's the darker blue circles. And basically, if you're actually wanting to increase physical activity, then having a system that an intervention that promotes overall activity is most effective. If you're wanting to prevent falls, structured exercise is most effective. Interestingly, if you're wanting to promote functional and particularly cognitive and emotional functioning, then recreation and sport came up well. And then we looked at whether this also applied to people with physical limitations. And although there was fewer studies, basically we still found similar relationships. And these numbers are the numbers of comparisons that are the basically intervention versus control comparisons that have investigated that combination of intervention and outcome. So yeah, overwhelmingly positive. We've also done Cochrane reviews, and so this is just, I'm just going to give you some examples of some. And so this was people with frailty, and so it was looking at mobility training for increasing mobility and functioning in people who met the definition of frailty. And we basically found high certainty evidence that targeting mobility did improve mobility. And so this was a lot of kind of functional exercises, programs that targeted sort of physical function and mobility primarily. So that might have included practice of activities such as walking, sit to stand, etc. Some of the studies also included strength training as well. We found similar findings. We looked at people after hip fracture surgery and also found here moderate certainty evidence of improvement. So yeah, I'm not going to go through the details, but that's all published if you'd like to look at the details. But the overall message is that we really can improve most outcomes in most people with physical activity, with targeted interventions. And this is our Cochrane review that looks at preventing falls in older people living in the community. And so here we actually found overall there's 108 studies. Of the 59 studies that looked at the rate of falls, so the number of falls that people were having, and this is comparing intervention and control groups. There's basically 13,000 participants across 59 studies with a high certainty of evidence that overall exercise reduces the rate of falls. Putting that into people, if we were to follow 100 people for a year, without exercise, there would be 850 falls. So with the type of falls rate that was seen in these studies, and you could actually prevent 195 of these falls with the types of programs that were in the studies. There was so many studies, we were able to break it down and look at different types of exercise, and exercise that primarily promoted balance and functional activities. We were able to give it a high certainty of evidence using those rigorous Cochrane methods that there was a 24% reduction. For the programs that also included resistance training, there was actually a 34% reduction, but there was fewer studies, so it only got a moderate certainty evidence. So we basically conclude that we need to be targeting balance and function for falls prevention, and we can add resistance training if we want to. And if the person kind of is agreeable and has access to suitable programs. Tai Chi is talked about in terms of falls. There was actually only a low certainty evidence that Tai Chi prevented falls. And looking at resistance exercise by itself, dance by itself, and just walking programs, there actually wasn't evidence that by themselves those interventions prevented falls. But yeah, there's been less investigation of those interventions. And here's an example of one of the programs that was tested in several of the trials. So this is the Otago program developed in New Zealand. So quite sort of simple functional exercises, sit to stand, balancing, going up onto your toes, up onto your heels, going upstairs, practicing turning, practicing with the feet closer together. So you can see it really is about control of your body in space. And within the Otago program, it's a progressive program, so it's tailored to the person's abilities. And so a key kind of message that we say with prescribing balance training is that we're really looking for the exercise to be challenging, but still safe for people. Because obviously there is a risk of falls while exercising. And the Otago program is being found to be effective when taught in 4 home visits from a physiotherapist or from a nurse trained by a physiotherapist. And that's just one example of an effective program. And so because of this gap really between what is provided for people and what the evidence says, we're interested in cost effectiveness. So we've done some various studies looking at economic aspects, and a more recent one, which was actually commissioned by WHO, was looking at exercise for falls prevention. And this is a detailed figure, but it's basically finding that there is some variability, but overall, many of the programs were actually cost effective by using the type of threshold that might be used to fund other interventions. And so this is a key interest of mine, that our systems have ways of funding pharmacological interventions, but we don't have such good ways of delivering non-pharmacological interventions, even if they have similar levels of evidence in terms of their cost effectiveness. And we work with health economists, and they're actually the health economists who are on the pharmaceutical benefits board. We've also done reviews looking at falls in people with Parkinson's disease. So what the actual exercise will probably need to look a bit different and be delivered in a specialised way, but exercise can also prevent falls in people with Parkinson's disease. And it was actually particularly for people with milder disease. And so this was exercise as a single intervention, which kind of makes sense that people with more serious disease might need other interventions. And in fact, we've also recently done a review looking at occupational therapy interventions, and so environmental interventions for preventing falls in older people, and finding high certainty evidence that in those people who are at a higher risk of falling, an occupational therapy intervention, so teaching home safety approaches, also at giving advice on home modifications, will actually prevent falls. And so, as I mentioned, we have a Centre of Research Excellence on prevention of falls injuries. We have a multidisciplinary group of people involved from different institutions around Australia. So they're our associate investigators. And so we've been working with the Australia and New Zealand Fall Prevention Society to update the guidelines, so the Australian guidelines on falls. And so showing, as I was saying, the really lack of attention for this area compared to the extent of the problem. The most recent falls prevention guidelines in Australia are actually from 2009. And so, yeah, we've been working on an update. And so we used some of that evidence that I've already shown you, as well as a recent World Falls guidelines that came out. And so we had a modified version of GRADE, giving a kind of certainty of evidence and a strength of recommendation. And so this work is actually work that we've done for the Australian Commission on Quality and Safety in Healthcare. And they're going to open a public consultation on these guidelines soon. So I'm giving you a little bit of a sneak preview. But basically in hospital, and I'm going to go through them quite high level, basically in hospitals, finding evidence for education, for multifactorial interventions targeting individual risk factors, and for comprehensive geriatric assessment and management in people after hip fracture, and for home safety interventions in people being discharged from hospital. In aged care facilities, also recommending multifactorial interventions, needing, again, not just assessing the risk, but actually developing a plan, and exercise also for people in residential care, which needs to be continued over time. The benefits were lost when people stopped the interventions. Needing additional serves of dairy, so evidence there, and the way that was implemented in the effective study was having the menus assessed by dietitians. Also vitamin D, there's evidence for in residential care, but not the once a year mega doses. And people with osteoporosis or a history of low trauma fracture having bone protective treatment unless contraindicated. And hip protectors being considered, not always realistic to actually to use, but there is evidence that they can prevent fractures if they're worn. In the community, basically that everyone should be doing exercise, so that should be starting targeting balance and mobility, but can also include strength training, and that people at a lower risk of falls should be attending community exercise or undertaking home exercise. People at some increased risk probably need some professional input, so from a health professional or a more trained instructor. And that people at also some increased risk should receive a home and community safety education, and that people at a higher risk, so for example, people who are falling more than twice a year, should actually receive an individualised assessment to look at other risk factors beyond exercise as well. And the ones that have been effective or been tested in Cochrane reviews have included use of assistive devices, medication reviews, podiatry, and strategies to address sort of concerns about falling, anxiety and depression. So that home safety comes up there as an individual, a standalone intervention as well. And that then a number of the trials have included people with particular risk factors. And so in people with visual impairment, they need to be, so due to cataracts, there's evidence to support cataract surgery. In people with foot problems and disabling foot pain, evidence for podiatry interventions. So those people who do have the cardiac sinus hypersensitivity will benefit from a pacemaker, but that's a small proportion of people. And decreasing psychoactive medications and other fall risk increasing drugs collaboratively. Using single lens glasses rather than bifocals or multifocals for people who go outside more, and taking care with new glasses. Vitamin D for those people who are deficient, but again, not the mega doses, and the osteoporosis treatment. And so then that's the algorithm from the World Falls Guidelines, which was published in Age and Aging last year. And so it divides people, as we have in the Australian guidelines, into sort of low, intermediate and high risk. And the purpose of that is really to keep on that kind of public health approach of the prevention for the kind of less frail people, but then the more kind of specialised and more interventions for the higher risk people. So yeah, basically key point from all of that is that exercise-based interventions can prevent falls and enhance mobility in people with diverse mobility levels, but people at increased risk of falls will also need other interventions as well. We know that physical activity behaviour is complex, and so we did a review of qualitative studies finding a lot of influences on physical activity behaviour, but there is evidence that can be, behaviour can be changed by health coaching, so this is for physical activity on older adults, and also by using activity trackers, so getting feedback. And so we've done a trial, the Change trial, where we use both health coaching and also activity trackers, so Fitbits, and we hope to publish that soon. But we did find the intervention was incredibly well received. We actually used physiotherapists to deliver that coaching intervention. And so that sort of COM-B model, which considers capability, motivation and opportunity, was found to really guide people's acceptance of the program, but then they also liked the autonomy, so having choice over the type of activity and also relatedness. They liked doing it with other people, and competing demands came up as well, as people's caring roles particularly. So basically physical activity behaviour is really quite complex, but it can be supported by coaching and activity monitors. But as we're very well aware, just having this evidence does not actually change practice. And so increasingly there's attention to more kind of deliberate strategies to support translation of evidence into practice, and also scaling up effective interventions to be able to be available to a lot of people. And so some of our trials that we're doing are ways of trying to deliver these interventions to more people in a scalable way. And so this is a trial that we're doing. It's also NHMRC funded, doing physical activity coaching for people with mobility problems. So bringing together the mobility and the physical inactivity aspects. And we've really worked to kind of plan an intervention that could be scaled up. We have a light touch intervention that's primarily online for women over 50, and Anne Tiedemann has got 2 large grants recently to be kind of trying to scale that up and deliver that in different settings. We're also working with aged care providers to deliver exercise interventions through telehealth, and also through sort of exercise videos and training of care staff. And we're also working directly with health professionals to, this one's in hospitals, actually in southwest Sydney, to support them to kind of better incorporate physical activity promotion into their busy lives, or their busy work days. And this is another trial that we're doing. It also includes Sydney and Southeast Sydney Local Health District. And yeah, please get in touch if you're interested in participating in any of these. So the key point there is that really we need to be genuinely partnering with providers if we're really hoping to implement and scale up interventions. But then there's qualitative work that scale up and funding decisions are not only guided by evidence. And so it's also important to look at other initiatives that are trying to change policy at a national or international level. And this is an initiative from WHO that was launched recently about better access to rehabilitation. So the Rehabilitation 2030 initiative. WHO also has a global strategy on falls prevention called Step Safely, and also a plan for physical activity internationally. And so these, sometimes we can be a bit cynical about these because they're sort of just documents, but these are really meant to be providing guidance for governments to help guide their investments. So I think these documents are an important piece of the puzzle. And in the WHO guideline, they talk about the importance of creating active societies, active environments, active people, and also active systems, and how that we need all of these aspects. And just very briefly, because we're just about on time, and another avenue for finding exercise opportunities for people is the Active and Healthy website. We also developed the Safe Exercise at Home website, which gives guidance for people on safely undertaking home exercise, and has kind of realistic case studies as well. We had a piece in The Conversation to try and get the message out, and we did get some media attention with our work that we did to try and get the issue more on the agenda. So basically, scaling up these effective interventions is complex, but we really need to be trying to communicate with decision makers. So yeah, just to wrap up, that we know that function matters more than age. These things are all interconnected and we urgently need solutions. We can prevent falls and enhance mobility. We can change behaviour with support, and we need to work together to test and implement these interventions, and to advocate for better funding of the interventions. And there's me practicing what I preach, undertaking a trail run very slowly but having fun, and actually with another professor of physio as well. And yeah, just like to thank everyone involved in all of that work. And then, yeah, we might have a minute or two for questions.
Hi, Cathie. There is one question sitting in the Q&A, just asking about whether we can train the brain with our elderly patients to help them not fall. And are there any proven programs to help patients who shuffle due to Parkinson's to reduce falls?
Yeah. So some of the Parkinson's falls exercise programs do actually address that. So there's by kind of, different techniques. So it's not my area of expertise, but yeah, I think that the programs that have been found to address falls, have been found to prevent falls in Parkinson's disease, probably have included a component addressing shuffling. And so whether that's by kind of giving guidance about step length, sometimes people use metronomes and kind of different things to practice. In terms of training the brain, I mean, to me, that's where the focus on balance is so crucial, because that basically is coordination. It's basically happening at the brain. And so we do need the muscles to be strong, but we also need the brain to be coordinating them in the right way. And as with any skill, practice is the way we get better at that. And so, yeah, really as much relevant activity as possible.
Great, thank you. And we might just give, if anyone has any last minute questions for Cathie, please pop them in the Q&A and we'll try and get to them. Otherwise, we are on 8 o'clock. So I just wanted to thank you again, Cathie, for joining us and presenting tonight. I'm sure everyone got something out of it and we really appreciate your time. And I don't know if we're going to get any more questions for that. We might just give it a few more seconds to see if there's any burning questions that come through. If not, Cathie, if there's any that do come through, am I able to forward them to you?
Yeah, definitely. And people, yeah, feel free to get in touch.
Okay, great. Yeah. Oh, okay. I think we might have. Yeah, we've got another question. Are there studies looking at peripheral neuropathy and diabetes with falls risk?
So yeah, and that's what comes into sensation being an important factor and different diseases impacting on sensation. So yeah, that is where peripheral neuropathy comes in. And actually, one of our colleagues at Neura has just been awarded a grant to actually do a sort of stepping intervention in people with peripheral neuropathy after chemotherapy. So yeah, but I'm not sure that there's any interventions yet specifically in that population, but yeah, definitely part of the puzzle in terms of the risk of falls. And possibly that's where the OT interventions come in, and also, you know, physio interventions with you know, use of walking aids or splints if the neuropathy is severe.